Welcome, everyone, to COVID-19 Provider Update number 95. I'm Dr. David Battinelli, Physician-in-Chief here at Northwell Health. And before we get started, a couple of housekeeping details. Remember to sign up for your CME credit. If you have any difficulty with that, give us an email and we'll get you going. And we don't have anything to declare with respect to disclosures today. And today we've got a relatively focused and I guess maybe relatively brief presentation, and we're going to be joined by our usual guest, Dr. Bruce Farber, our Chief Public Health and Epidemiology Officer, who will give us the year-end on COVID-19 and flu update, and then his nickel down for what we can expect in 23. We'll have a brief discussion and a book, and we will be on to the new year. Take it away, Bruce.
Thanks, David, and Happy New Year to everyone. It's a pleasure realizing that we are now in our third year. Although it didn't hit the United States until February, it certainly was circulating 3 years ago in many countries. Next slide. So let's just summarize what's happening as we approach the end of 2022. Well, influenza rates are all over the place. They're declining in selected areas. However, there can be a second wave, and as I will show you, New York was sort of in between. Community COVID rates remain high, and while there are higher hospital rates in New York, there have been relatively few deaths or ICU admissions for COVID. The COVID booster and influenza vaccine rates remain very low. And despite high rates of COVID, there will be continuing easing of routine surveillance in the next few months relating to admissions and pre-procedural procedures that we anticipate will happen in the first quarter of 2023. New variants continue to evolve at alarmingly fast paces, leaving the future vaccine policy very unclear. The CDC has called for a large conference in January to decide what they are going to do going forward and whether it pays to make additional updated boosters or just stay with what they have now. And I'll show you some very controversial data on that. And then finally, if I had to say what's going to happen, it would be the last bullet point. And that looks like there will be ongoing endemic COVID, and that may well likely be the major driver of immunity in our country and in the world, particularly with low vaccination rates. And for those of you who remember our summary 2 weeks ago, I will report that 2 weeks later, you now realize that there are 45 million cases of COVID occurring every day in China. And as predicted, and the modeling was really quite accurate, COVID is running rampant through China and is expected to take several months to cause this enormous wave with death rates that are clearly unknown. The Chinese are reporting no data at all about daily rates, deaths, hospitalizations, and crowding. And, so we really don't know what's going on. Next slide. All right, so let's look at the statistics. Last week, it looked like we were in pretty good shape. And this looks at all influenza-like, not influenza, but influenza-like respiratory illnesses of people showing up to various facilities. And this is the United States, not New York. And you can see that for the first time, flu rates started declining, which gave everybody some cautious optimism that this early wave of flu might not be quite as long-lasting as is often the case. It may be a little too soon to celebrate, and I'll show you why. Next slide. And if you look at positive flu rates, and this is New York, you see the curve is just starting to bend down. Now, it's not way down, but that's encouraging. And our hospital rates are leveled off and are certainly not climbing. Although this past weekend was very bad at many of our facilities, it's hard to get a handle on that because many other places were closed, and rates right after a holiday are very difficult to interpret. Next slide, please. And this is the Northwell rates. And this comes up until 12/21, which is the latest I could get data right before the holiday. And what you see here is our flu rates are still high, maybe leveling off that you would see in the next week's data, but our RSV rates have fallen significantly. Our rhinovirus rates have fallen significantly. And look at our respiratory illness rates, including rhinovirus and enterovirus, and they are all significantly down. COVID rates are pretty much stable, or if anything, a little bit higher. Next slide, please. And this is, again, the national statistics, and you can see that there is declining flu rates, or at least hospitalizations due to flu in the United States over the last 2 to 3 weeks. So this is a very good and hopefully persistent finding that we are seeing. Next slide, please. Now, one thing I want to teach people about is the length of contagion for influenza. And this is the data, the best data that I could get, which is about 10 years old. And what it looks like is how long you shed flu and are contagious when you acquire influenza. And what you can see is, you're probably contagious a little bit longer with influenza B, which is not a problem at the present time anywhere in the United States. It tends to occur late in the season, right before flu ends for the year. But if you look at influenza A and we put a big circle around the data, you see that most people dramatically stop shedding live virus between day 3 and day 5. So if you have influenza and you're feeling better, day 3 is probably okay. If you have influenza and you're not feeling okay and you remain ill, 5 days. Now, the two exceptions are immunosuppressed patients can excrete influenza for a much longer period of time, not surprising, and young children tend to be infectious for a longer period of time. So I remind people that somewhere between 3 and 7 days is how long you're contagious for influenza. In the hospital, we generally use 3 to 5 days, depending upon the illness, because we need the beds so badly. Next slide, please. Now, one other topic I want to bring up is this issue that keeps coming up in the news of the, two viruses at once. And how common are we seeing people infected by both influenza and SARS-CoV-2? Not so much with RSV, so I'm not going to show you any data about those two, but SARS-CoV-2 and influenza, and what does it mean? So between 2022 and 2023, influenza started rising. As you know, it wasn't here earlier in the epidemic, and particularly in the pediatric population. And it's an early season, as you know. So let's see what data has come out. And this came out in MMWR about 2.5 weeks ago. Next slide, please. And here's what you can see. Between October 1st of 2021 and April 30th of 2022, 575 pediatric patients were hospitalized and identified. And 6% of them were co-infected with SARS-CoV-2 as well as influenza, and 543, the overwhelming majority, just had influenza. And you can see that on the slide. So a small proportion of about 6% get co-infected. And recipient of the influenza vaccine was less prevalent among those with co-infections, 17%, compared with those who had influenza alone, 42%. A higher proportion of patients with co-infection than influenza received mechanical ventilation. They were sicker and they had higher death rates. So COVID simultaneously being infected with influenza is a bad prognostic sign and not helpful. Next slide. And if you look at the death rates, let's look at the data. The number of deaths was relatively low, but there were 44 pediatric deaths in this cohort of patients that were put together. And 7 of the children who died were co-infected with SARS-CoV-2. Among influenza vaccine eligible children who died, 0 out of 6 with co-infections, and 5 or 16% of 31 with influenza had been vaccinated against flu. Another small but I think relevant piece of data to suggest that influenza does decrease the risk of death in people who are co-infected. The most common complications among those who died with co-infections were pneumonia, acute respiratory distress syndrome, and bronchitis. No big surprises. Next slide. And the conclusion was that all pediatric patients who received testing for both influenza and SARS-CoV-2 virus and who were hospitalized or died with influenza had more underlying comorbidities and were not fully vaccinated against seasonal flu. So those two things contribute to pediatric deaths, meaning underlying medical problems or not being vaccinated. Influenza and SARS-CoV-2 co-infections were infrequent, representing 6% of hospitalizations and 16% of deaths within this population of roughly 500 children. An increased use of invasive and non-invasive mechanical ventilation among infected people was noted, indicating potentially more severe disease among these young patients with co-infections. Next slide, please. So this is, again, the problem. I mean, these data, you cry when you see these data as an infectious disease doctor. This looks at the proportion of people who have been vaccinated with the bivalent booster. And if you look at the numbers, they're pretty abysmal. 12% in the young age group, in the 12-year-old and above, 14%, in the 18 and above, close to 15%. And the only group that has any degree of uptake is in those over the age of 65. And there it's only 32%. So this is why I said my conclusion right up front is that ongoing endemic COVID infections will continue to occur throughout our population and will promote ongoing immunity. And the price we'll pay is the roughly 400 deaths that we're running currently, a lot less than it was a year ago, but not totally insignificant either. Next slide. So what is happening? I will just again show you how quickly these data are changing and what it means to us now, and then show you the data with regards to these vaccines and these variants. So the updated US genomic data indicates that there's now an important shift occurring with XBB gaining on BQ.1.1 and BQ.1, the variants that were dominating the New York area and the United States. And while BQ.1s are dominant overall, the Northeast is now seeing XBB grow quickly and another variant, XBB 1.5, grow. And you can see that on this map that comes out weekly. I look at this map every week when it comes out from the CDC. Next slide, please. So this is what New York State looks like, and you can see how quickly these colors and these variants change. It's shocking to me how fast it happens. And you can see that B.1.1, which was so prevalent just around Thanksgiving and Christmas, it's now falling off, and we're seeing a new strain, XBB. Next slide, please. So this is what it looks like on the scheme, and you will see how one mutation, only one single mutation, F486P, is the one that changes XBB to XBB 1.5. But that one mutation is responsible for a dramatic change in which variant is circulating. And that's why this problem will not end, because there's a myriad of these mutations that can occur in one of these genes. And you can see that although we talk about these variants being so different, it's only a matter of a few mutations that separates out XBB from XBB1 from, BQ1 and BQ.1.1. And that's why you're seeing this ongoing drive. But they're all at least a part of Omicron, which is why I think that unless something dramatically changes, baseline endemic immunity will continue to occur from the myriad of people who are constantly getting infected. And that's what's just about to happen in China, only they haven't had the luxury of having it happen over a 2-year period of time with a fairly high initial vaccine rate. They're having it in one fell swoop that will mean lots of problems for them. Next slide. And so let's look at what's happening in the United States. And this is specifically New York. I like this slide, and this shows that everything is really relatively stable, except hospitalization rates are rising for one subgroup, and that's people over the age of 70. And for that matter, it's over the age of 65 and 62, but it's just much higher in people over the age of 70. And that's where you're seeing this new XBB variant in a very poorly vaccinated group of people. Next slide, please. So what does it matter? How many people say to you, I'm not getting the bivalent booster because it's really not that good to begin with? So let me just show you some of the data on how good the bivalent booster is. And I'm not here to say it's a great booster, because we all know it's not a great booster, but it's a lot better than nothing. And that's the data that I want to show you. So the issues are that not all the studies conclude the same thing. So let me just give you 3 studies before we kind of wrap up this last of the year update. So this is data that just came out. This was published in MMWR on December the 16th of this year. And this looked at the effectiveness of the bivalent booster in preventing people from being sick enough to go to urgent care or emergency rooms. Anybody who needed medical care, or at least thought they needed medical care for developing COVID, was included in this cohort. And they had good numbers. 78,300 emergency room visits or urgent care encounters were studied in people with COVID. And almost 9,000 or 12% of these and 69,000 control patients were identified. 31% were unvaccinated, and 5% of the adults received a bivalent vaccine, a very poor uptake, 5%. So let's look at that 5% and compare them to the other 95% of people who did not get vaccinated and see the results. And among 15,000 hospitalizations of people with COVID-like illnesses, 9% or roughly 1,500 case patients and 14,000 or 91% of control patients were identified. 26% were unvaccinated, and again, 5% of people received a booster. Next slide, please. So here's the results. The vaccine efficacy of a bivalent booster after either getting 2 or 3 or 4 monovalent doses, they mixed them all together to get good numbers, against ER and urgent care visits for COVID-associated illness was 56% compared with no vaccine. So you're, 56% efficacy compared with not getting that bivalent booster. It was 31% compared with the recipients of the last monovalent booster if it had been dosed 2 to 4 months earlier, and 50% compared with recipients of the last monovalent booster greater than 11 months. Now, for those who have not gotten a bivalent booster, which the large share of our population has not, they're almost all greater than 11 months, because remember, the only booster that we're giving now is the bivalent booster, and it's been out for quite a while. So vaccine efficacy of a bivalent dose, either after 2, 3, or 4 monovalent doses against hospitalization associated COVID illness was 57% compared with no vaccine, 45% compared with the recipient of the last dose greater than 11 months earlier. So it's not perfect data. It's not an amazing vaccine, but there is efficacy in it. And as again, I'm not sure that the data would be any different compared to a monovalent vaccine, but let's look at 2 more studies before we wrap up to try to answer that question for you. And I want to answer the question of going forward, what about all these new variants? Next slide. Okay, so here we go. This came from the New England Journal of Medicine about 3.5 weeks ago, and this looks like at neutralization of Omicron subvariant 275. Now, I picked this because, one, it was the best paper out there, and secondly, because 275, as you could see on that curve, is very similar and will come through many countries, including our own likely, just the way these other subvariants do. So it's a very good representative example of all of the things to come. And this looks at how good a bivalent booster neutralizes the 275. And there were 428 participants. The bivalent booster elicited a potent anti-neutralizing antibody against BA.275 subvariant, regardless of previous COVID vaccine or infection, okay? And the response was 2 times as high against compared to BA4 and BA5 subvariants, and 3.5 times as low as compared to the ancestral strain. So once again, this study showed pretty good results. And if you want to see the results, look at the last two columns on the slide, and you see this was one pre-vaccine, the light gray, and then the darker brown. You can see it goes up about threefold. And so, again, it's not 20-fold the way the initial vaccine is, but it does make a difference. Next slide, please. And again, the same data, but it breaks it down in terms of those people without previous COVID infection and those with previous COVID infection on the bottom. And what you can see is if you compare the two bars on the top to the two bars on the bottom, you'll see that anybody who previously had COVID gets a better boost from the BA bivalent vaccine than people who did not have COVID. Now, we're running out of people who did not have COVID, as you know. The overwhelming majority of people in the United States have had COVID. As a matter of fact, many people have had COVID many, many times. So this just demonstrates the point I want to make in the beginning of the talk, which is this is the way forward, which is ongoing COVID to constantly boost your immunity, not long-lasting immunity from it, but enough immunity to keep you out of the hospital, keep you out of dying, and getting a booster every once in a while. If you haven't recently had COVID, kind of does the same thing. And this is what I think our future holds for us, unless there's a big breakthrough in vaccine technology. And this is the kind of data that the CDC and the committees will be looking at in January to decide what's going to happen 6 months after people's last bivalent booster. Next slide. So the last set of slides I want to show you, which are show you the controversy of that not everybody shows data that's totally aligned with one another. And this looks at the low neutralization of selected variants of Omicron by 4 doses of the parental vaccine that previously got, and compares it to the bivalent booster, which is the same question being asked. And they looked at all of these subvariants, BQ.1.1, XBB, the one circulating in New York, 275 I just showed you, BF7, which is circulating in China. And they conducted a study to evaluate the neutralizing activity of 3 human serum panels collected from individuals 1 to 3 months after getting 4 regular doses of the vaccine. This was serum that was banked. 1 month after a bivalent booster, or 1 month after a bivalent booster with a history of prior COVID. And this is kind of, again, what our options are. Next slide, please. And here's the results. So 4 doses of the regular vaccine, not the bivalent, did not elicit robust neutralization against many of these new evolving variants. And what you can see on this slide is that 1 to 3 months after the dose, and just look at the 2 extremes on the slide. On the left-hand side, the brown, you can see the hatched line on the bottom shows how much immunity you probably need to escape infection. And you can see if we were living 3 years ago, which we're not, the data is amazing. I mean, that's what came out when we first saw these vaccines, which we were so far above what was necessary to inhibit the organism from infecting that the efficacies were, remember, 95%. Everyone thought it was a miracle. Now, if you look 3 years later at the right-hand side of the slide and you look at XBB, which is the virus that is currently growing and circulating in New York, and right next to it is BQ.1.1, the second common circulating variant in New York, and you look at those hatched lines, you can see that you're barely straddling the line. As a matter of fact, there's many, many people who are well above that line, which is why there's so much breakthrough COVID. Next slide. Now let's compare the same data in people who got the bivalent booster. And I'm going to break that down into 2 slides. One is 1 month after the bivalent booster in people who never had a history of known COVID. And what you can see is the results are better, quite frankly. Again, not dramatic. On the left-hand side of the slide, you see this enormous antibody that we saw 3 years ago produced. And now on the right-hand side of the slide, you see it's better than it was in the last slide, even though these people did not have previous COVID. And next slide, please. And if you see, if this is people who did have a history of COVID, and you can see, for the most part, people are above the line. So this is why I do believe that even though the bivalent vaccine is not a miracle and B5 is long gone and won't come back anytime in the near future, you still see the benefit of that vaccine, which is why I encourage people to get the vaccine, because it is much better than the prior vaccines, and it's a lot better in people who have had a history of COVID. Next slide. So the B5 booster elicits a better neutralizing antibody against newly emerged COVID subvariants than the parental initial vaccine, that individuals with a history of SARS-CoV-2 infection develop higher and broader neutralization than people who have after the bivalent vaccine. And all of these subvariants exhibited the greatest evasion against vaccine-induced neutralization. Next slide. So we're going to wrap up with one last study, and I will turn it over to David. And this is the Paxlovid rebound study. And I show you this because I think it's so interesting in how we have to be so careful in our critical thinking and not immediately jump on things when they appear in the papers. So you will recall that wasn't that long ago when people began noticing that a relatively small 5% of people who got Paxlovid got a rebound, and they were found to be contagious again, and they had to go back in isolation. And even Dr. Fauci took another course of Paxlovid, even though most people say don't do it. And so this study looked at Paxlovid and the rebound studies. And what it demonstrated is something I think very interesting. And that's that if you look at people who have SARS-CoV-2 without Paxlovid and no treatment, a significant and really not that different percent of people who get Paxlovid also get rebound, which is why it's so important to have controls. And this, is what this study looked at. And let me just show you the data of comparing people who had rebound after Paxlovid 5 days, and it occurs in the 2 to 8 days after you finish Paxlovid, compared to people who felt better, got better with COVID, and then felt worse thereafter. Next slide, please. So the time to viral clearance was similar in both the group that got Paxlovid and the control group that never got Paxlovid, 6.8 versus 6.7 days. No real difference. The time from symptom onset to first symptom resolution was also not significantly different, 10.4 versus 10.7 days. And the time from symptom onset to the first negative antigen test was also not really different, 6 versus 6.3 days. And that applies to people who got Paxlovid and those who did not get Paxlovid. Next slide, please. So the conclusion was that it demonstrated that overall viral testing rebound incidence was 14% and a symptom rebound incidence of 19% among Paxlovid treated people. Now that's a lot higher, much, much higher than what most of the other studies report, where it was in the range of 2 to 6%. Both viral 9% and symptom rebound 7% occurred in the absence of treatment with Paxlovid. So just think about that when you decide whether you're going to use Paxlovid or not. And I think that's my last slide. I wish everybody a happy and healthy new year. And this virus is not going away, but we will do more and interesting things. And I certainly appreciate everybody paying attention to these talks, and thank David for the opportunity to doing them.
Thanks very much, Bruce. Yes, let's just wrap up with a couple of thoughts. We've got a lot of work to do in the next couple of years with respect to, I assume, regaining the trust of people in how we should be approaching science. And we talked about this, I remember, really early on when quickly people said, you can't trust the science because it always changes. And then we're like, this is a bad starting point. That's the definition of science, right? It's the pursuit of and discovery of everything new, as you've been pointing out so nicely along the way. I'm not really sure where we went wrong. I think it was, as you pointed out in that last slide, being a little bit overly optimistic, or others might say zealous, with respect to the discovery and just how we were going to put a lid on all of this. My other concern was just there was such a poor understanding in the community, not their fault, about RNA technology. It was so new, and all of the confusion about whether, if you gave something that was developed either as an RNA virus or otherwise, that this was somehow going to be incorporated into your own DNA, and all the OB issues, et cetera. What's your message? What do we need to be telling people in 23?
Well, I mean, in the long haul, I'm optimistic because it's the only way forward. And, truth does eventually rule. We're in a difficult time now. I think we all know that. And I don't only mean in the United States. I mean, look around the world and how there's been such a backlash against democracy in so many places, and reasonable science. But I think ultimately, this has to work, and because there is no other choice, quite frankly. And if we don't believe in science and truth and going forward, then we will pay a hefty price. And I think that many people have paid a hefty price, and hopefully they're starting to see that. I mean, we will have a long way to go. Don't get me wrong. I'm not Pollyanna, and I don't think anything's about to change quickly. I'm hopeful that that better minds and calm minds will start thinking things through better in the future. And I think, David, that applies not only to our approach to science, but it applies to gun violence, drug use, and so many of the problems, crime that we're dealing with now. So, I'm optimistic, but in the short haul, like you say, it's going to be a lot of work to do in the next year or two. It's not going to be overnight.
Well, again, thanks for everything you've been doing for us. And we're going to continue this next year. And this makes a nice transition to this week's book. It'll be quick. This is a book called The Calling, Why Healthcare is So Special, by Quint Studer. This was recommended to me by Dr. Ted Strange, our leader of ambulatory and general medicine in the Staten Island and the Western region. Next slide. And it's a little bit about what you just sort of talked about. First part of helping people is to be assertive about breaking down the stigma around stress, trauma, mental health issues. Next slide. And he argues the calling is in our DNA in terms of we as healthcare workers. And then what do we have to actually accomplish? Next slide. And so it's really about, principles, the passion, the purpose. And I'll just leave you with one of the, my take on this entire book is really all about, that the ability to connect to purpose, to remain positive and optimistic, and they may not necessarily be the same thing, and the willingness to inspire and manage change and keep moving forward is the only way to be successful with respect to leading. People think you're going to have all the answers, and all you're really going to do is make the best judgments based on the information you have, and be open, be self-aware enough to understand that you actually don't have all the answers, but you sort of have the answer for the day, and the passion to keep going. Last slide. So again, it's a great book, broken down into some nice chapters. Appreciate Ted's recommendation. Anybody else has any more recommendations? I'm all ears. Had no idea we were going to be, near 100 of these by the time we finish. I'll keep the books coming. So, Bruce, thanks again. Happy New Year to everybody. Thanks for your feedback, and most importantly, thanks everybody who behind the scenes really makes this so easy for Bruce and I and other guests to keep going. So we'll see you in a couple of weeks, and Happy New Year.